I think so, مش كده? أولاً, thank you to Professor Sharif Mogawer. Thank you to Dr. Abir. Thank you for the attendee. And thanks for the organizing company. And it's my pleasure to be among you. And it's my pleasure to feel that nutrition is starting to be part of the clinical management approach. I'm going to start in a different way. So the slides are going to be there. We're going to move the slides. بس أنا حابة split my topic into two portions. We are facing a challenging topic. Nutrition support on one side of a challenging patient. And the challenging patient is a patient considered critically ill surgical patient. So in my opinion, doctor, I would consider the patient throughout a critically ill patient. The patient with an underlying some kind of a medical disease that is heroic, and he's going into a major surgery, liver transplantation. Why else does the patient be considered a challenging patient? Number two, severely malnourished in majority of cases, if not in all cases. Patient is severely malnourished to the extent, ممكن حضرتك تقلب first? Yes, please. To the extent that the malnutrition score of my patient is considered one of 6 variables that correlate with the survival rate. Number two, the patients are mostly, again, if not all, in a status of negative nitrogen balance. So the patients are usually very poor on the lean muscle mass. Number three, the patient has a certain ambience surrounding them. We can go to second slide, where the assessment of the patient is kind of unique. And when I'm talking here assessment, I'm talking about assessment clinically, assessment nutrition. And when we start talking about the nutrition support part, I'm going to discuss exactly why there's a different ambience when it comes to caloric requirements. The patient is different in that aspect. And finally, this is a patient who we cannot overfeed nor underfeed. يبقى أنا لازم أبقى very just when I decide the nutrition support. So let me take you to the second part of it. خلينا. The second part, or the other side of the equation, is the nutrition support. And since I need nutrition support, this means that the voluminous intake of food is going to be very, very poor. And that's why I'm trying to make a decision to give my patient some kind of support. And when I say nutrition support, then I'm talking about enteral, parenteral, or a combination of enteral and parenteral, what we call metabolic support. Priority in all critically ill patients will always be enteral. And when we're talking enteral, we mean either oral or tubal or both. There's always a possibility for both. طيب نرجع بقى نقول في nutrition support إيه steps لأي critically ill patient. You have to assess the patient clinically. فبنعمل physical examination history. You have to assess the patient nutrition wise. يبقى لازم أخد a very good nutrition assessment, anthropometric, use the in-body, use whatever tools you have. عشان كده بنحب يبقى للliver transplantation in particular a nutrition support team. هو التيم اللي مسؤول عن إنه يحط البلانز ويعمل assessment as accurate as possible. Then you start assessing the nutrition needs, starting from calories, carbs, proteins, fat, etc., etc. And then you start to put the plan, and remember, a continuous and a consistent follow-up of the patient for liver transplantation is a must. From the very beginning, in the pre-operative stage, up to 3 years or even more in the post-operative stage. So let me tell you, starting with the caloric requirements, this patient has a very unique ambience. The patient has many collaterals surrounding the status, a lot of stress, the surgery. The patient could be exposed to a ventilator. The patient can go into infections, sepsis. Maybe even we can suddenly be exposed to a multiple organ failure. So I'm not dealing with only the basal metabolic rate when I come to calculations or with the thermic effect of food, but I have other factors that I should take in consideration when I am calculating the energy requirements. يبقى كده أوصل لإيه? How am I going to calculate? It's not that easy. How look, practically speaking, to be honest with you, subjectively, we just take the actual weight and I subtract from 7 to 15 kilos of whatever fluid is there, ascites or bilateral lower, you know that, Dr. Mon. لكن, to be accurate, I need the indirect calorimetry, which is not available. Number 2 or number 3 is going to be the equations, which is very tedious. So you choose. If you have the indirect calorimetry, thumbs up. If you don't have it, Try the equations. If it's too tedious and taking a long time, we just go with subjective assessment of the body weight. Take the dry weight as possible as you can. Remember, assessment has to include an initial assessment in the pre-operative and immediately within 24 hours of your patient's admission. And it has to go on continuously in the immediate post-operative and throughout the patient's life. Next. Remember, part of the assessment should include laboratory investigations. You're going to do the liver function tests, serum albumins and proteins. And here, this is a very important part of the assessment, knowing that albumin is not simply an indicator of malnutrition, but it is kind of a surrogate. It helps me. It is something that just kind of a guardsman standing beside me. It can give me a clue that this patient is definitely going into a negative nitrogen balance. Electrolytes, liver functions, kidney, serum creat. Serum creat could act as a very good indicator for the negative nitrogen balance. And I honestly use it, and it's very, very accurate in most of the cases. يعني لما الاقي serum creat below 0.8, this patient is definitely with a very poor muscle mass. Next, please. These are the general outlines that I already summarized in general, and I want to go on next to how to start processing this case. First of all, classification to pre-operative, post-operative, or the immediate post-operative, and a long-term. Now, in the pre-operative, there are many recommendations in nutrition to give high protein. And this is something that we always kind of consider very, very significant. Most patients come in with restricted proteins. And up to today, I see cases where the patient is told, don't eat more than kind of a match box size of meat. That is not fair for your patient. You need to give a very high protein intake. Diet has nothing to do with the attacks of encephalopathy. We do agree that you do not give it as one single bolus. You give it frequent meals, but it's a must to give a very good amount of at least 1.2 grams at least per kg per day for these patients. Number two, immunomodulators. It has shown in some studies that it does give beneficial outcomes on the long run. Things like omega-3, things like arginine, glutamine, they do essentially help the patient. What about in the immediate post-operative? Same lines, بس هنضيف كمان, you want to give the patient a formula high in fibers with a probiotic. These have shown better outcomes on the long run with such patients. Take that in consideration. Remember, start enteral nutrition as early as possible. If you have a contraindication, an absolute contraindication, then you want to consider parenteral nutrition, or maybe you want to consider both, as we mentioned before. And when you're discussing parenteral nutrition, please remember that a combination when it comes to the lipids, لأن في ناس restrict the lipids, you don't have to restrict lipids. You can give a combination of the medium chain and the long chain. This gives us a better outcome for most of our patients. What about the long run? I want you to remember one item. Your patients are very prone to develop weight gain and develop obesity. يبقى لازم يبقى في دماغي وانا بدي البيشنت a discharge plan, a follow-up plan في outpatients في units بتاعتكم to follow up on weight gain. Patients start to gain within 6 months a lot of fat mass, and they start to lose a lot of muscle mass. So they need a plan for this obesity. Next, please. وقفت. Can we turn while I keep going? Anyways, okay. لما نيجي بقى للobesity, I'm going to tally على كلمة obesity. يبقى I'm concerned that my patient may develop obesity. But remember one thing. Again, this is very important. When you're dealing with a regular obese patient, we can use what we call permissive underfeeding. يعني ايه؟ الobese patient جاي لي مثلا 120 kilos, 100. أنا بتكلم على ordinary patient. I can simply calculate the ideal body weight and use it to lose weight. But when the patient is a patient going into a major surgery or coming out of a major surgery, never apply this technique. Why? لأن this technique depends على the peripheral stores of fat, making it oxidated or oxidized and accordingly losing the peripheral stores of fat. This thing is kind of impaired when there is a major surgery. I cannot apply it in patients going for liver transplantation. La before, wala after. This was just kind of a red flag. We don't want to do that. لأن في ناس كتير قوي when they go obese, you just like بيدوا له مية, بيدوا له intermittent fasting, بيدوا له ketogenic. Don't do permissive underfeeding. You have to give a very regular, well-planned program for such patients. Next, please. Now, enteral nutrition first priority in the post-operative. Jejunostomy, if you need a tubal, is preferred. Nevertheless, I leave this to the surgeon's option or choice. Formulas are to be introduced. يعني بلاش نصر قوي على الدايت. Of course, if the patient is okay, ما عنديش contraindication, everything is fine, start regular diet, especially if your patient is staying for some time in hospital. Unrestricted diet. Actually, I use the formulas in addition as a way of supplementation and fortification, just to make sure the patient is receiving all the needs of macronutrients and micronutrients, and make sure the patient is getting enough minerals and vitamins and electrolytes. The macronutrients, I put them here. عايزين نبقى very cautious with carbohydrates. يعني ما تزودش عن 2 grams per kg per day if possible. If you need to go a little bit higher to sustain muscles, you can, but you need to keep an eye on the weight gain of your patient. Number 2, fat. Make sure the fat is not more than 30% of the total caloric intake. And we go between 1 to 1.2 grams. على فكرة الفات دايما kind of equivalent للproteins. But in some cases, I can go down and low to 0.3, and I can go as high as 1.2. Next, please. Anyways, we need to keep an eye on other complications in the post-operative period. Obesity is a major complication. It starts developing within 6 months of the operation. And then we need to also focus on things like ischemic heart, increased triglycerides, elevated triglycerides. Patients can develop diabetes, patients can develop hypertension. And remember, there are many reasons for the obesity to develop. One of it is in the patient بيخرج بقى feeling that he wants to start eating. Families are very happy. They start feeding the patient. And the medications, corticosteroids, immunosuppressants, etc., etc. The immunonutrition in patients going to liver transplantation and after liver transplantation is a must. And remember, you can add glutamine, arginine, omega-3. And to be honest with you, it is a must. Is it a must recommendation? The answer is no. يبقى لو جينا في guidelines, ASPEN and ESPEN اللي هم nutrition societies, do they say like you must do this? The answer is no. But by experience, we find that the more you boost the immunity, the more you give things like that, بالذات glutamine will enter glutamine, helps healing of surgical injuries and helps healing of any kind of leakages, etc., etc. So would like you to give us a chance to try things like immunomodulation, like nutrition support in the right way. Next, please. Recovery in the hospital, regular diet, no restriction if the patient has no contraindication, no complication. Most patients will gain weight. Keep an eye on that. Next, please. Complications, as I have just mentioned, obesity and other complications. Next, please. كلها على فكرة تصب في sustaining a good lifestyle in order to prevent it. These are the significant criteria for obesity, why obesity happens in such patients and what to do. And of course, we're going to monitor the patient's weight. Monitoring of the BMI, of the triglycerides is a must. Next, please. Finally, a good team, a well-trained nutrition support team, presence of some kind of food hygiene culture. Your patients could be at a certain stage considered immunocompromised. That's when you need to have a very clean kitchen and kind of a nursing team, dietitian team, who know exactly how to approach such a patient who might be isolated. It's not always the case, I think, in liver transplantation. But in our unit, in the Air Force, they do have their own unit. And in most of the cases, they treat them as an isolated case with an immunocompromised concept. We have a team for food safety hygiene. We do have a team for the nutrition support in particular. Have your feeding pumps. If you use tubes, tubal feeding, a feeding pump is going to be a must. It's going to be a plus. It's something that's much, much better than just inserting the vial tube. If you decide doing a tube gastrostomy or jejunostomy is kind of preferred by experience, but again, it's always a surgeon's decision. And finally, in summary, look at your patient from 2 aspects. It's a challenging case. It is a case with severe malnutrition. You cannot overfeed, you cannot underfeed. Look at nutrition support with its unique criteria. Presence of an indirect calorimetry is a plus. Nevertheless, you can always be very practical and very fast in assessing. Have a nutrition support team. It's going to remove part of the pain. It's going to be really something to relieve the institution. And finally, remember, one major complication in the post-operative is obesity. And I thank you so much.